طيب, I promise this lecture is lighter than the previous one, and it's a way more fun. So for common pediatric infectious diseases, part 2, we have a common clinical syndrome. Let's start with the first syndrome. So imagine yourself, you are the primary physician who have these two patients. So the first one is a 3-year-old with low-grade fever, runny nose, cough, and sore throat. The second case, 6-year, with a high fever and severe sore throat. And you examine the throat for both of them. And the first one, you found a bilateral erythema, and the second one found a bilateral enlarged tonsils with opposite date. So what is your management for the two cases, and what is the differences between the two cases?
The first one is virus, I think, and the second one is bacteria.
Okay, why you think the first one is a viral, and why you think the second one is a bacterial?
Because it's low-grade fever, runny nose, cough.
Okay, and the second one?
البص يا دكتورة اللي على
The opposite. Okay, but it can present with viruses can present with oxidative pharyngitis. Just we mentioned the EBV, if you remember. It can present with oxidative pharyngitis too. What else you would consider in the two cases? What's the differences?
Enlargement of the tonsils.
Both they can have enlarged tonsils. What's the differences? Why this patient, I thought it's more of viral, and this patient, I thought it's more of bacterial.
عشان المانجمنت.
Okay, but why I will manage this one with antibiotic and this one without antibiotic?
عشان
What else? No, something.
إذا صار أوكي تفضلي.
No, go ahead.
إذا صار فايرال ما نعطيه antibiotics. إذا صار بكتيريا نعطيه.
Okay. Is it all bacteria we will give antibiotic? Not all bacterial pharyngitis we prescribe antibiotic. But there's important difference between the two cases. Anyone can, it's written.
The fever.
severe sore throat يا دكتورة.
No.
Maybe the cough and the rhinitis with the left
Okay,
one.
cough, rhinitis, all suggestive of viral, as your friend mentioned, and also the low-grade fever. It's the age differences. So children less than 3 years, or less than 3 years, it's more of viral. School-aged children, 3 years and above, the peak between 5 to 11, it's more bacterial, and we are specifically concerned about one type of bacteria causing pharyngitis, which is, anyone know which bacteria?
Streptococcus.
Which one of the strep?
Group A.
Group A, yeah, Group A streptococcal. This is only the one situation we'll treat with antibiotic, and we will know why we will treat this patient with antibiotic with the Group A streptococcal. So we will discuss now pharyngitis, which is the infection of the pharynx and tonsil. The main causes, as we mentioned, it's viruses, more than 80%. It can, any of the viruses, rhino, adenocorona, enteroinfluenza, parainfluenza, RSV. Bacteria only cause 20% of the pharyngitis. And most importantly, it's a Group A strep. There is another types of strep, Group C, Group G, but Group A is the most common, or the commonest cause of bacterial pharyngitis. Also Yersinia, Mycoplasma, Francisella, but the most common is Group A, and the most targeted therapy with antibiotic is for Group A. For clinical manifestation, as you can see from the first cases, what's the differences between viral and bacterial? We'll start with the age. Viral can any age, but mainly in children less than 3 years. A bacterial, it's a school age. Group A, it's a school age infection. The peak is 5 to 11 years. The onsets for bacteria, it's usually sudden. For viral, it's like variable onsets. If the patients have any other viral or prodrome like abdominal pain, cough, rhinitis, hoarseness, conjunctivitis, diarrhea, it's all suggestive of viral. For tonsillar hypertrophy, it can present with both viral bacteria, but more bacterial. For the oxidate, it can be both, but it's more bacterial. Also for palatal petechiae, it can present in both, but it's more with bacterial, mainly with group A. Cervical node, usually with the viral, it's bilateral, or sometimes you have generalized lymphadenopathy. For bacteria, usually it's only unilateral. Rash, if it is with a viral, it's a viral example. For bacteria, if it is with group A, they will have a scarlet fever rash, which is the sandpaper appearance. But it's just only with group A. It doesn't happen with any other bacteria. So just to help the clinician to decide about diagnosis or pre-probability to send the test, it isn't used in practice, but sometimes some physician in emergency room, they will use this criteria. It's called modified Centaur criteria. So if you have high grade fever, you give a 1 point. If you don't have a cough, you give 1 point. If you have unilateral swollen cervical lymph node, you'll give 1 point. If you have exudate, you'll give 1 point. If your kids between 3 to 14 years, you give 1 point. And if you have 4 and more score, the probability or risk of group A, it's more than 50%. So you can send the test for group A and wait, then you can get the antibiotic.
دكتورة احنا مطالبين فيها هذه؟
It's good to know. For a diagnostic test, you have the rapid antigen and you have throat culture. For rapid antigen, it's a rapid and can be done quickly in the emergency room, and it have high specificity. That means if it is positive, you are ruling in the disease. But the problem, it's a lowish sensitivity, so it's ranging from 70 to 90s. So if you have a negative test, you should do a throat culture and wait for the result prior to prescribe antibiotic. So why we will treat group A strep? Any thoughts?
To prevent acute rheumatic fever.
Exactly, to prevent a non-suppurative complication, mainly acute rheumatic fever. It can also decrease the duration of the acute illness and prevent suppurative complication like retropharyngeal abscess, peritonsillar abscess, but it's the main reason why we treat a group A strep pharyngitis is to prevent non-suppurative complication, mainly acute rheumatic fever. So that's why we have a window prior to start antibiotic. We have a 9 days for the effectiveness of antibiotic. So that's why we will do the test and wait for the result prior to prescribe antibiotic. So this is the complication. As we mentioned, we have suppurative, non-suppurative. For suppurative, as I mentioned, retropharyngeal, peritonsillar abscess, otitis media, sinusitis, mastocytitis, it can have can complicate group A strep pharyngitis. Non-suppurative, we can have acute rheumatic fever, and we can have acute glomerulonephritis. Some they have reactive arteritis. Also toxic shock syndrome, as we mentioned earlier, with superimposed first. All application for pharyngitis. Some they mentioned neurological complication of group A strep with mainly behavioral problem, but it's not common. So the main reason we are treating group A strep is to prevent acute rheumatic fever. Acute glomerulonephritis is a common with group A, but more with skin lesions, like scarlet fever. But it's not prevented with the antibiotic. So treatment, it's mainly penicillin. Mostly group A strep is sensitive to penicillin. Alternative therapy is amoxicillin. It's as effective as penicillin with less frequency and more palatable taste. If the patient is allergic to beta-lactam, we can give them macrolide or clindamycin, depending on the sensitivity. So with a suggestive of viral infection, and he had all the viral protocol, that's symptomatic therapy. But if you have patients suggestive of bacterial infection, the typical school-aged children with a unilateral cervical lymph node enlargement with oxidative pharyngitis and high-grade fever, you send a rapid test, as I mentioned, because it is highly specific. And if it's positive, give antimicrobial therapy. If it is negative, you need to do throat culture or you do a rapid molecular test. So let's go to the case number 3. This is a 6-month-old infant with fever, vomiting, and excessive crying. And you do examine the ear, and you found, anyone can mention the finding? What is this?
Acute otitis media.
Exactly, why you meant acute otitis media? What is the finding in the examination? Bulging tympanic membrane, erythema. Also some patients, they will have absence red.
هذا السويلنج اللي طالع هذا في
ما
التمبانيك
اسمع.
ممبرين، السويلنج اللي طالع في التمبانيك ممبرين هذا.
ايوه هذا bulging tympanic membrane. Also erythema. Some patient, they will have absent red reflex. Some they will have otorrhea with while you are examining them, and some they will have perforated tympanic membrane. And what's your management for this patient? And 6 months. This is patient 6 months, and if another baby like 3 years old with unilateral otitis media, and he is well looking.
معليش دكتورة بس قطع قبل ما سمعنا وش كنت تقولي.
Okay. What's your management for this baby? He's 6 months with otitis media, and if you diagnosed another baby 3-year-old with unilateral otitis media. تسمعوني؟
اسمعك يا دكتورة بس يقطع كثير مرة.
طيب دقيقة بس أغير الشبكة. أتمنى الحين أحسن.
إيه أحسن يا دكتورة.
طيب كنا نتكلم what's your management or is there any difference in your management if this is a 6-month-old with acute otitis media or a 2-year-old with acute otitis media? تسمعوني؟
اي واضح.
طيب so for a patient with less than 2 years, we will start with the treatment directly. But if patient more than 2-year-old, there is a chance of spontaneous resolution, more than 50% the chance. So if the patient is not toxic and he didn't present with a bilateral otitis media and he didn't present with a high-grade fever, we will just hold on antibiotic. And we discuss with the family if the patient after 48 hours or 72 hours still having the symptoms to come back to have antibiotic. But usually we will just hold on antibiotic. And also the difference in duration. If more than 2 years old, we start antibiotic. Now, recent RCT suggests 5 days as equal to 7 to 10 days. So if more than 2 years, we will just prescribe antibiotic for 5 days. If less than 2 years, no, still the evidence suggests 10 years to prevent complication. So why otitis media happen? It's multifactorial.
دكتورة
أيوة.
less than 2 years you suggest 10 years 10 years medication.
ما أسمعك مهند.
أنت قلت less than 2 years
2 years. 10 days.
10
Sorry.
days قلت 10 years.
Sorry. Okay. So why otitis media happened? It's a multifactorial, but it's mainly due to increased negative pressure in the middle ear and mucus accumulation and secondary bacterial overgrowth after viral upper respiratory tract infection. Clinical presentation for a younger patient, they will present with fever, irritability, air tugging, and for bigger children, they will point for air pain. Also, both they can present with air discharge. So signs of otitis media, it's a clinical diagnosis. So you have to have all the skills to diagnose acute otitis media. They will have, as we mentioned, there is bulging, dullness, absence of light reflex. Sometimes you can't see air fluid level or autouria during your examination. So etiology of acute otitis media, mainly bacterial. But as I mentioned, spontaneous resolution happened in more than 50% of cases. That's why in younger children, the resolution is high and we are not prescribing antibiotic. And for bacteria, the main causes we have, this is what we call a respiratory bacteria or auto respiratory pathogen. It's a strep pneumoniae, Haemophilus influenza, Monoxylactiralis. Strep pneumoniae, although we have the vaccine and we have recent vaccine, pneumococcal conjugate vaccine 17, but still we have strep pneumoniae as a common cause because of serotypes that are not covered by vaccine. For Haemophilus influenza, initially it was a typable cause, but after vaccination, the non-typable is the commonest cause. Monoxylactiralis, there's no vaccine for monoxylactiralis, and it's usually presented with more lighter symptoms. So for clinical approach for otitis media, as we mentioned, the age is important and the symptoms is also important. So if the child is less than 2 years, we agreed to treat those patients regardless of their presentation. But if the patient is more than 2 years, if they have ill toxic appearance or high-grade fever or severe otalgia, or they present with a bilateral otitis media, we will treat. If no, just give symptomatic therapy and reassess after 48 hours. If improved, just continue the symptomatic therapy. If not improved, we will treat. Now the choice of treatment. Usually for otitis media, the antibiotic of choice is high dose amoxicillin. But if the patient have high risk of resistant, because they are using amoxicillin within the last 1 month, or they have a concurrent conjunctivitis, we thought about Haemophilus influenza, and Haemophilus influenza, usually they will have some resistance to amoxicillin. So at that time, we will give amoxicillin clavulanic acid. If the patient no, we would just give high dose amoxicillin. And if the patient's improved, we'll just continue the therapy. As we mentioned, if less than 2 years, we will give 7 to 10 days. If more than that, we can give 5 days. If patient showed no improvement or not compliance in oral medication, we can give only 3 doses of IV ceftriaxone. And if no improvement, just consider other methods like tympanocentesis or adjusted therapy according to culture, but this is not common in immune-competent children. So what's the common complications of acute otitis media? As we mentioned, the patient can have tympanic membrane perforation. They can have conductive hearing loss. Some common manifestation is mastocytitis. The serious complication is if the patient have brain abscess secondary to otitis media or epidural abscess. Also, otic hydrocephalus is a rare complication when the patient presented with pictures of high ICP but without hydrocephalus. Now let's move to acute bacterial sinusitis. And prior to move to that, just to remind us about the sinuses, usually acute bacterial sinusitis is a complication of viral infection. As you see, the mucous membrane of the nose, almost the same, continue through all the sinuses. And also, we have the osteomyelial junction. So if there is any blockage here, it will accumulate the mucus here, and also there will be a chance to bacterial overgrowth, and patient will present with acute bacterial sinusitis. So usually pathogenesis, as we mentioned, acute bacterial sinusitis is almost always preceded by upper respiratory tract infection. And there is 3 key elements, as I mentioned: the patency of ostia, and the quality of the mucus, and also the function of there is dysfunction of the ciliary apparatus. Usually this is not common in immune competent, but there is some patient with cystic fibrosis, they will have problem with the ciliary function. And as I mentioned, if there is overproduction of secretion after upper respiratory tract infection, acute bacterial sinusitis will happen. Usually it's diagnosis. So the patient presents either with the 3 presentation. The most common presentation is the patient present with a persistent symptoms or worsening symptoms. So patient present with a nasal discharge or cough for more than 10 days without any improvement. That we call it a persistent symptoms of acute bacterial sinusitis. Or patient, they can have like acute upper respiratory tract infection, then they will have a weaning phase, then they will have a worsening of the symptoms on day 6 or 7. They have fever and they have nasal discharge. Severe symptoms is less likely presentation. Patient present from the beginning with the high fever and permanent nasal discharge for more than 3 days. The most common cause of acute bacterial sinusitis, as we mentioned earlier, it's our 3 bacteria: strep pneumoniae, Haemophilus influenza, Moraxella. Viruses, it's unlikely to cause sinusitis, but it can in some cases. Staph and anaerobes, it's unusual cause of acute bacterial sinusitis in immune-competent children. So, as I mentioned, acute bacterial sinusitis, it's always a clinical diagnosis. We don't do imaging. Anyone know why we didn't do imaging in acute bacterial sinusitis?
ممكن لانها اكيوت فما تحتاج يعني انه مو مالجنت او شيء مثلا، فما يحتاج انك تسوي له ايمجنج يعني ممكن مثلا تحدد باشياء ثانيه غير الايمجنج.
Any other thoughts? Because the presentation of acute bacterial sinusitis can overlap with a common cold. And if you image any patient with common cold or with acute bacterial sinusitis, you will have the same finding, which is the thickening of the sinuses or air fluid level. So patient with common cold, they will have the same imaging appearance of sinusitis. So we will offer diagnosed sinusitis in patient with common cold, and we will offer prescribed antibiotic. So that's why we don't do imaging in acute bacterial sinusitis. Unless we thought about complication, which is like brain abscess or something, we will do imaging. And also if the patient not responding to antibiotic, we will do imaging, and sometimes we'll do sinus aspiration just to have susceptibility. When we will treat acute bacterial sinusitis, also there is a high chance of spontaneous resolution. We just treat if the patients present with the severe symptoms from the beginning, with a high-grade fever and purulent nasal discharge for more than 3 days, or the patient have a worsening course, or if the patient have concurrent bacterial infection like acute otitis media or pneumonia, or patients we are suspected having a complication like a brain abscess or a mastocytitis, or patient having underlying condition like patient with cystic fibrosis or patient with bronchial asthma. So if the patient have any one of those, we will treat the patient. If the patient doesn't have any one of those and even have prolonged course of more than 10 days, as we mentioned, of just mild symptoms, we will not treat directly. We will just observe him for 72 hours. If improving, just continue symptomatic therapy. If the patient not improve or having any one of the previous criteria, we will treat the patient. And usually, as we mentioned, it's amoxicillin, any of otitis media, pharyngitis, or bacterial sinusitis. For acute otitis media and acute bacterial sinusitis, we will go for high dose amoxicillin. For pharyngitis, we mentioned it's penicillin the first choice, but if we will go with a regular dose amoxicillin. But if we thought about, we are afraid about any resistant, if the patient have Haemophilus influenza or patient receiving amoxicillin in the last month, we will go with amoxiclavulinic acid. If patient improving, we'll just continue our therapy for 7 days. Or if the patient not improve, that's when we will go to sinus image or sinus aspiration. Okay, clear? Any question? واضح؟
واضح.
واضح.
طيب في أي interruption؟ إذا في أي interruption بس قولوا لي أعيد، الله يعافيكم. مشكلة.
تمام.
طيب خلينا ناخذ بريك كذا 1 minute. Okay, let's move to the second clinical syndrome. So this case, this 6-year-old presented with redness, swelling in the chin with golden crust. So what is your diagnosis and how you will manage this patient if he's looking well and febrile, if your patient ill and febrile? Anyone can volunteer? So what do you think?
Impetigo, because as we see, there is crusted lesion.
Okay, good. So what's your management? If your patient looking well and febrile, we give topical or systemic antibiotic if your patient
No,
is
topical.
looking well.
Topical.
Topical. Okay, and if the patient's ill and febrile, we will give
Systemic.
system. Okay, so impetigo, it's usually present with either. There is two presentations of impetigo. There is non-bullous impetigo and there is bullous impetigo. The commonest presentation in children is non-bullous impetigo, as this patient in the picture. Usually impetigo secondary to which bacteria?
Streptococcus or Staphylococcus?
Exactly. So usually we are afraid only of complication of the patient's ill and febrile, as we mentioned with the streptococcal patients can have, sometimes if they are immune compromised, they can have toxic shock or ill from the beginning and immune competent. We are also afraid of toxic shock, either with the group A strep or with a staph. But usually it's a self-limited. So now go to skin and soft tissue infection. And usually diagnoses like by eye. So let's start with the first two groups, erysipelas and cellulitis. From the picture, what's the differences between the two syndrome? Which one is more superficial? What do you
Maybe
think?
erysipelas.
Okay, yes, erysipelas is more superficial. It's only contained to epidermis and to sometimes to lymphatic system. That's why it is a well demarcated, because it will go with the lymphatic chain. Cellulitis is the infection of the dermis and subcutaneous. That's why it's a deeper infection and it's a diffuse one. What's the commonest cause?
Cellulitis, Streptococcus.
Or staph. Erysipelas is mainly streptococcal infection. For both treatments, we can give a course of oral antibiotic that's active against staph and the strep. So now let's move to impetigo, as we mentioned. Can anyone describe the lesion of impetigo? This is non-bullous impetigo. It's usually localized, and what they mentioned is golden crusted lesions. And usually it's with streptococcal and less commonly with the staph, the non-bullous, and the bullous mainly staph infection. And also, as we mentioned, for the treatment of non-bullous impetigo, if it is localized and patient looks well, it's with topical antibiotic. If not, we'll give a course of systematic antibiotic. In bullous impetigo, it's mainly secondary to staph, and also we give the same treatment. Now let's move to folliculitis. So what's the differences between folliculitis, furnicles, and carbuncle? By just watching, which one is more superficial?
وش دكتورة؟
Which folliculitis and furnicle and carbuncle?
Carbuncle
are
more superficial.
Carbuncle. Okay. What
I
about
think
folliculitis?
فورنيكل لأنه واضح إنه طالع شوي يعني.
Folliculitis.
Okay. Folliculitis. Folliculitis, it's only in the epidermis and in the hair shaft. Furnicle, no, it's go down to epidermis because see the redness here and the pus. So it's more deeper to the dermis. Carbuncle, it's just aggregation of either folliculitis or furnicles. with a multiple drainage point. So it can be superficial, it can be deep. The main causative agent,
جروب A ستوكوكس.
it's a less common, but the commonest is staph aureus. And the management usually, if it is just folliculitis, we will just give them a warm compressor or topical cleansing agents. If it is furnicles and carbuncle, we advise, it depends on the size, but sometimes it required a minimal surgical drainage. Now let's go to ecthyma and ecthyma gangrenosa. So anyone can describe ecthyma? Is it deep or superficial?
deep.
Deep.
Superficial.
Deep. Okay, it's a deep, and we can see it's what we call this lesion, ulcerative lesion. What's the difference between ecthyma and ecthyma gangrenosa? Just by examination or by looking. Ecthyma gangrenosa, what is this? What we called it?
It's gangrene or necrosis.
Exactly. So ecthyma gangrenosum, from its name, they have a necrotic center. Which one you think it's more serious, ecthyma or ecthyma gangrenosum?
Gangrenosum.
Gangrenosum. And what is the causative agent?
Pseudomonas. Pseudomonas.
Gram-negative, mainly Pseudomonas. So it is a worrisome sign. So if you are in the emergency room and you have a patient came with a fever and ill-looking, and you examine him and you find ecthyma gangrenosum, you should have empiric coverage of Pseudomonas until proven otherwise. Ecthyma, it's mainly streptococcal infection, and it's not as serious as ecthyma gangrenosum. And ecthyma gangrenosum, it can present in immune competence, mainly in patients with immune compromised condition with the neutrophil problem. So we'll just go over them again. So impetigo, as we mentioned, it's localized, highly contagious, caused by staph or group A strep. As we mentioned, impetigo 2 form. There is bullous and non-bullous. Bullous mainly with a staph, non-bullous with a group A strep. And the typical age of targeted children is between 2 to 5 years of age. And this is the bullous impetigo in infants. It's mainly due to staph. The management, as we mentioned, topical antibiotic. The most common examples is mupirocin, effective for the mild cases. Or if patient looking ill, we can start with narrow-spectrum antibiotic, targeting staph and the strep. For severe infection, we give duration 1 week to 10 days, not 10 years. For patient with folliculitis, so we mentioned it is a superficial infection of the hair follicle that's only present as single papules or pustules. The region can be single or grouped. If grouped and involved the hair shaft, we called it as carbuncle. And staph aureus is the common cause of folliculitis, carbuncles, or furnicles. And the management, it's usually, as we mentioned, it's resolved spontaneously, but sometimes we give a topical antibiotic or a cleanser agent. For furnicles and carbuncles, we mentioned what's the differences. Usually also the causative agent is staph aureus, also the treatment almost the same, application of topical antibiotic, hot compressors, and if it's large, it requires surgical drainage. And this is again the furnicles, staph aureus is the causative agents. We mentioned ecthyma and ecthyma gangrenosum, and what is the differences, what is the causative agent, and we describe ecthyma as a deep ulcerative infection, penetrate through dermis. and the cause is usually group A strep biogen, and the treatment we give antibiotic targeting strep. And for ecthymogarniosum, we mentioned it is a series, and it's characterized by a necrotic lesion, and it's almost secondary to gram-negative, especially Pseudomonas. And we mentioned we should have empiric coverage of Pseudomonas until proven otherwise. And this is again a picture of ecthymogarniosum in a patient with neutropenia. Then we mentioned erysipelas and cellulitis, and what is the differences between them, which one of them are superficial, which one are deep. So erysipelas is the upper dermis and lymphatic system, and it's well demarcated. It's most common cases, it's secondary to group A, but staph is rare. Treatment is antibiotic targeting strep and staph. Usual duration, no one will go beyond 14 days, and usually 10 days. Cellulitis, as we mentioned, it's involving dermis and subcutaneous tissue. Most common cause strep and staph, and usually only antibiotic we will give targeting strep and staph. And if there is complicated cellulitis with, let's say, abscesses, required surgical drainage. And we go like, this is not important. So all the skin infection, subcutaneous infection, remember Staph aureus is the causative agent and group A strep. So let's go to our last syndrome. So this is 9-month-old infant presented with fever for 3 days. Examination, she looks well, and temperature 38.9. There is no focus of infection in your examination. What is your next step? And which clinical infectious syndrome you should think of? Any thoughts?
It is acute bacterial infection.
You think about bacterial infection? Okay, bacterial infection, but which, like targeting which organ in the body?
UTI.
UTI. So what is your next step?
Urine culture.
You send urine culture, or prior to that you send urine analysis?
ليش دكتورة؟
So urine analysis
دكتورة
or urine. أيوة.
ليش قلنا UTI؟
It's the most common presentation in children without with a fever and without a focus and well looking. If it is ill looking, okay, I will think about sepsis, about other bacterial infection. But if the patient is well looking and in your examination you didn't find any focus, there is no pharyngitis, no acute otitis media, no other focus, so it's the most common presentation.
Clear.
Okay. So urinary tract infection, how can we diagnose urinary tract infection, and what is the definition of urinary tract infection? Is it the positive urine analysis? Is it positive urine culture? And if it is positive urine culture, is it presence of any colony, or is it significant colony numbers? And is it in any patient or in symptomatic patients? That's what we will know. So definition of urinary tract infections. I changed my slides based on the recent Saudi Pediatric Infectious Disease Society urinary tract infection guidelines. So now all the recommendation will go through Saudi Pediatric Infectious Disease. I remove all the American and other Australian guideline. So Saudi Pediatric Infectious Disease defined UTI as a presence of significant bacteriuria. So it's not any number of presence of colony-forming urine or any number of bacteria in the urine, and of urinary pathogen, not of any other pathogen. And for definition of significant bacteriuria, we will mention that later. In asymptomatic patients. So like our patient, she presented with a fever. So if the patient is asymptomatic and mainly in adult, we will not label the patient as having urinary tract infection, we will label the patient having asymptomatic bacteriuria, and there is no need to treat those patients unless there is certain condition like a pregnant lady we will treat. But for asymptomatic bacteriuria, there is no need to treat. So usually the pathogenesis, it's just colonization of periurethral mucosa of a GI bacteria, and it will ascend to a bladder, ureters, and kidney. And there is certain bacteria, they have virulence factors like E. coli and Klebsiella proteus. There is also host risk factors. It's help in the pathogenesis of UTI if the patients have neurogenic bladder, if the patient having obstruction, if the patient have a reflux. Also, in boys mainly in less than 3 months old, if they are not circumcised, the frequency of UTI is increasing by almost 8-fold comparing to circumcised boy. So for etiology, it's mainly E. coli in 70 to 80% of the cases, and Klebsiella also, it's a common. Proteus, Pseudomonas, Enterobacter, it's not that as common as E. coli and Klebsiella. Enterococcus also common. Other causes of UTI in certain hosts like Candida and immune-compromised or catheterized patient, it can cause candiduria. Group B, mainly in neonates. Rarely Staph aureus can cause UTI. Staph sabrophyticus in adolescent care. As we mentioned in the common viral illness lecture, adeno can present with hemorrhagic cystitis, but mainly in immune-compromised patients. TB, it's rarely present with sterile pyuria. So clinical features of UTI, if the children is less than 3 months, usually they will present non-specific symptoms, fever, vomiting, lethargy, irritability, sometimes with poor feeding, sometimes if UTI not diagnosed or the patient not presented with like in acute presentation, they will present with the failure to thrive if not treated. Less common, they will present with jaundice, but jaundice mainly, I will say, with patients with sepsis in those age group. Infants and the children more than 3 months, they can present with also the same fever, but if patient fever, they can point to, they have like the dysuria, they have also frequency, urgency, and the other also manifestation. Also, we need to differentiate if it is a lower UTI, upper UTI, In children, we mentioned if there is presence of fever, many clinicians, they will call it upper UTI and they will treat with pyelonephritis. Why we need to differentiate? Because the duration of antibiotics difference. If it is only lower UTI, we will go for 3 to 5 days. If it is pyelonephritis, we will go for 10 to 14 days. So many clinicians from my practice, if fever present, it's a pyelonephritis. So diagnosis, we mentioned the diagnosis is with presence of significant bacteriuria, but urine microscopy and urine analysis can help us. So presence of pyuria, it can indicate presence of urine UTI, but also pyuria, as we mentioned, can present with a different presentation, like patient with Kawasaki, they will have sterile pyuria. Patient with different clinical condition can have pyuria. And what is the definition of pyuria? It's presence of more than 5 white blood cell in centrifuged sample or more than 10 white blood cell in uncentrifuged sample. Urine analysis, it's a very helpful screening tool, and usually in ER we will go with the urine analysis because if they have a high negative predictive value, if it is negative, the patient unlikely to have UTI. But the Saudi pediatric ID, they recommend to repeat urine analysis if the first one is negative. So what is the importance of urine analysis? We have two tests, leukocyte esterase test and nitrate test. Leukocyte esterase test is the surrogate of a presence of biuria, a presence of white blood cells. It's the enzymes in the white blood cells. When it's breaked, it will give leukocyte esterase test. Nitrate, it's the product of conversion of nitrite to nitrate by certain gram-negative. It's not with all the urinary pathogen, it's only with a specific gram-negative, mainly with the Proteus, the nitrate will be positive. If two is leukocyte esterase and nitrate test positive, it's highly indicate that we have a UTI. If both negative, they have unlikely the patient have UTI. So it's a useful screening tool, but it's not confirming the diagnosis. So what confirms the diagnosis is urine culture. And what is the meaning of significant bacteriuria? It depends on the way we collect the urine. We collect the urine is by suprapubic aspiration, and it's the ideal method in neonates, or if the patient have any congenital anomalies like severe labial adhesions, we will go for suprapubic aspiration. And because it is directly to the bladder, so presence of any number of colony forming units, it's a significant. Then the second best way is the transurethral catheter. So this is the best choice in infant and non-twilight trained children. And what is the significant growth? If it is more than 50,000, we mentioned it has significant growth. And if it's in symptomatic patient, we diagnosed UTI. If it is only the growth and the patient asymptomatic, we mentioned it is asymptomatic bacteriuria, and we will not treat unless we have a certain condition. But if patient also symptomatic, we will go with a lower colony forming unit. We can go with 10,000. And if the patient is twilight trained and we educate them how to collect the urine, so we can take a clean voided specimen. But because it is a clean voided specimen, we will go with a higher colony forming unit because it's not direct to the bladder or not through catheter. We will go with 100,000 colony forming units. And the Saudi pediatric also will go with 10,000 for clean voided sample if patient is symptomatic and biuria present. Okay, clear?
Clear.
كلير واضح.
clear.
Okay, so what about collection of urine through urine bag? It's not recommended because of high contamination. It's only helpful if it is negative because it will rule out UTI. But if it is positive, we don't know it's a contamination or it's through a real infection. So it's not recommended to take a urine through urine bag. So as we mentioned, the infant and younger children present with fever and no clear focus, we suspect UTI, or if the patient presented with older children with urinary symptoms, we will send urine. So initially, we can send urine dipstick and microscopy, but the Saudi pediatric, they recommend to send culture in the same times. And so if the patient is will appear and afebrile, if the urine is urine dipstick and microscopy positive, we will start empiric antibiotic targeting the urinary pathogen. If negative, as I told you earlier, they recommend to repeating the microscopy after 48 hours or wait for the final urine culture. If the patient is febrile or ill appearing, we start empiric antibiotic directly while awaiting the final result of urine culture. So for treatment, we will go with oral or IV. Evidence showed both are comparable in the efficacy, especially in children more than 2 months. If less than 2 months, because it's difficult to give oral and we don't know about the absorption in those young children, so we will prefer to go with IV. In ill and toxic children, better to give with IV till they are improving, then we can shift to oral. So now what's the empiric coverage? So in North America, their E. coli and Klebsiella pneumoniae, they are sensitive to ampicillin. So their first choice of antibiotic is ampicillin or Bactrim. But unfortunately, here in Saudi Arabia, we have a high resistant and for E. coli Klebsiella resistant to ampicillin, but they are sensitive to ceftriaxone and aminoglycoside. So the first empiric coverage for patients is to go with third generation cephalosporin and or aminoglycoside till the culture results came back. And if the culture results came back as sensitive to ampicillin, we can de-escalate to ampicillin. That's when we start IV. When we start oral, we can go with first generation cephalosporin or with augmentin. So that's what I mentioned. So if it is inpatient, we can go IV empiric is ceftriaxone. If patient is not improving, or alternative, we can go, we can add gentamicin, or we can start gentamicin alone, or give, sometimes they will give only 1 dose gentamicin. This is only to cover the possibility of ESBL. And treatment duration, as I told you earlier, it's ranging from 7 to 14 days. Till now, trial is coming for shorter duration, but till now it's 7 to 14 days for patient with a pyelonephritis, or if the patient is febrile UTI. If it is outpatients or only cystitis, we can go as I mentioned, first generation cephalosporin or second, but for me I will go with the first, or augmentin, and the duration usually ranging from 3 to 7 days. So now your patient, if you recall, our patient is a 9-month, and this is her first UTI. So for first febrile UTI in patient less than 3 years, it's recommended to scan the patient with abdomen ultrasound to rule out any possible anomalies. And if normal results, okay, you can stop there. And if abnormal results in ultrasound, you can go for micturition cystourethrogram or Feuding cystourethrogram. This is for first febrile. And the ultrasound, usually you will defer it, like better to do it like 1 month or 2 weeks after the illness, just so you confused about the presence of urinary debris or something can complicate the pictures. If a child present with a recurrent UTI, and they defined recurrent UTI as present of 2 more episodes in a 12-month, or present with complicated UTI like with perinephric abscesses, or patients not improving to antibiotic for like the 14 days duration, or patient present with non-E. coli UTI, because I mentioned patient with non-E. coli UTI, they found it to have more chance of congenital anomalies. This is just an association. Or patient have a family history of vascular reflex. At that time, you better, in the same time, you go for ultrasound and Feuding cystourethrogram together. And if you have any abnormal result or reflux present, you refer to the patient to urology or nephrology. To give them, if patient have high grade vascular reflux, you can start prophylaxis antibiotic, or if the patient have any congenital anomalies that required correction. So that's it for UTI. Any question? Any question?
Everything is clear.
نعم.
Okay. And we are done. في أي سؤال؟
ما قصرت، الله يعطيك العافية دكتور. بس في
دكتور عندي سؤال بس بسيط اخير.
ما اسمع إيش؟
عندي سؤال اخير بس.
اي تفضل.
وش الكومبليكيشنز اللي ممكن تصير اذا مثلا صارت اليورين باك بوزيتيف؟ انت قلت تو ذكرتي ان البوست يورين باك يعني ما نوت ريكومندد انه اذا كان
ايوه،
بوزيتيف لا نسويها. طب وش الكومبليكيشنز اللي ممكن تصير في حاله ان سويناها يعني؟
انه high contamination rate, so area is not clean, so if you collect the urine through urinary bag, you will have a chance to have a positive, there will no, you will have a positive urine culture, you have high chance to have like E. coli. And if the patient like present with fever, you will be in dilemma, you will treat the patient or not to treat the patient. So you might offer diagnose UTI and offer prescribed antibiotic unnecessary. واضح؟
جميل جميل جدا، يعطيك العافيه.
في سؤال؟
ايه في سؤال يا دكتورة، والله تو
إيه.
ماتش. وش المفروض نعرفه من الليكتشرز دي؟ يعني هل نعرف كل انفكشنز ولا نعرف المود اوف ترانسميشن بس، ولا نعرف المانجمنت؟
بالنسبة للفايرال
إيه.
lecture, as we mentioned, the clinical presentation will must comment clinical presentation or most important, ولا the clinical presentation we highlight. أنا صراحة خصوصا الفايرال حتى وأنا أجهزها حسيت إنها مرة طويلة، بس الكوريكولوم حقكم كذا مكتوب والأوبجكتيف كذا مكتوب، فخفت إني مثلا ما أحط ولا حاجة أو مثلا على certain viral syndrome ما أحط شيء وبعدين يجيكم شيء في الاختبار أو شيء وتتورطون. ف I included everything، بس في الشرح كنت أحاول to stress على الimportant point. هذا بالنسبة للفايرال. وحاولت إنه to include تقريبا كل الانفورميشن اللي في الريفرنس حقكم عشان خلاص بس الليكتشر حقتكم ما تذاكرون يعني أي مكان ثاني. وترى الليكتشر كثير يعني بتشوفون سلايدز كثيرة بس كلها صور يعني حتى بعض الصور مو لازم يعني كل الكلام مكتوب. بالنسبة للكومن بيدياتريك اي دي حتى أنا ما يعني مثلا لو تشوفون choice of antibiotic ماني مثلا في السكين سوفت تيشو قلت لكم بس انتي ستاف انتي ستريب، ما ذكرت بالتحديد بالضبط ايش، بس مثلا في الفرنجايتس مهم تعرفون انه مثلا بنسلين اللي تارجتنج جروب اي ستريبت، في الاكيوت اوتايتس ميديا هاي دوز اموكسيسيلين، في الساينوسايتس وين تو تريت وين نوت تو تريت، في اليورينري تراكت انفكشن also important to know which the first choice of antibiotic. لو في أي مشكلة تبغون ما أعرف تبغون أعيد لكم الليكتشرز ما عندي أي مشكلة.
لا
بس
ما يصير.
بس هذه أنتوا حاولوا تقرونها، وأنا الأسبوع الجاي عندكم سيريس بيدياتريك اي دي. أتوقع الليكتشر ما هي طويلة، فممكن نتناقش إذا كان في عندكم أسئلة زيادة أو شيء في الليكتشر الجاية.
الله يعطيك العافية، ما قصرتي.
أنا حرسل الليكتشرز للليدر وهو يرسلها إن شاء الله. طيب في أي سؤال؟ في سؤال ثاني؟
يعطيك العافيه.
يعطيك العافية دكتور.
يلا بالتوفيق إن شاء الله.